All right, welcome to The Explainer. Today, we're going to break down the really complex and honestly fascinating world of reproductive medicine. We're talking about the whole spectrum, right? From the challenges of infertility all the way to the science behind contraception. So, to get our heads around all this, we're going to start with a really simple but, powerful idea that comes straight from our source material. And that's the garden analogy. Just think of it this way. Managing fertility is a lot like tending a garden. Sometimes you're trying to help something grow, and other times, well, you want to keep the soil fallow. This idea is going to guide our entire discussion today. Okay, so let's dive in. Here's the roadmap for how we're going to tackle this. First, we'll look at the fertility investigation itself. Then, we'll break down the diagnosis for both female and male factors. After that, we'll get into modern solutions, what's known as ART. And finally, we'll flip the script and talk about the other side of the coin, contraception. So first up, the fertility investigation. This is all about uncovering the why. It's where the clinicians really become master gardeners, right? They're trying to figure out exactly why a seed isn't sprouting. And right out of the gate, this is so important to understand. Infertility is absolutely a shared issue. Look at these numbers. 40% of the time, it's related to female factors. Another 40%, male factors. And that last 20% is either a combination of both or it's just unexplained. So it's really not a one-sided problem at all. Okay, so let's start with the female side of the equation. This is all about checking the soil and the signals. In our garden analogy, that means looking at things like the uterus, the fallopian tubes, and the hormonal signals that really run the whole show. And as you can see from this chart, a huge chunk of cases, we're talking 30 to 40%, come down to ovarian issues. This is often the first place doctors look, and for a really good reason. Problems with releasing an egg are, by far, the most common cause. So, what's really interesting here is how doctors break down these ovarian causes. It's kind of like detective work. They look at hormone levels, specifically FSH and estrogen. Think of FSH as the signal from the brain telling the ovary to get going. By looking at these levels, they can figure out if the communication is breaking down somewhere or if the problem is with the ovary itself. It really guides them to the right diagnosis. And this is the crucial point, really. The single most common problem with the ovaries, this thing called anovulation, which just means an egg isn't being released, is also the one that responds best to treatment. So that's actually some really hopeful news for a lot of people. And check this out. It's not all high-tech labs and crazy equipment. This slide shows one of the really clever, kind of low-tech ways to see if ovulation is happening. By looking at changes in cervical mucus, you can tell which hormone is running the show. When progesterone takes over after ovulation, it gets thick. But if it's still watery and really stretchable, that's what spinbrookite means, it's a sign estrogen is still in charge and an egg probably hasn't been released. Okay, so if the hormones are good and ovulation seems to be happening, the next step is to check the plumbing. Are the pathways clear? We're talking about the fallopian tubes, which are like the irrigation lines in our garden. The gold standard for checking this is, well, it's a mouthful, laparoscopic chromoperturbation. But basically, they use a colored dye to see if it can flow all the way through. It's like checking for a clogged pipe. All right, let's switch gears and move to the other half of the equation. It's time to look at male factors. And in our garden, this is all about analyzing the fertilizer. So for men, the first big test is almost always a semen analysis. And it's incredibly specific, but you can boil it down to these 4 key numbers. First, how much is there? The volume. Second, how many are in there? The concentration. Third, how well are they swimming? That's progressive motility. And finally, what shape are they in? Morphology. But hang on, let's focus on that last one for a second. Morphology. The shape. This number is pretty wild. You would think you need a really high percentage of perfectly shaped sperm, right? Nope. According to the strictest criteria, you only need 4% to be considered normal. Just 4. It's kind of mind-boggling when you think about it. So, you do all this investigation and you find a problem. What's next? Well, this is where we get into the really powerful tools of modern medicine, designed to help cultivate that garden. We're talking about assisted reproductive techniques, or ART for short. This table gives you a fantastic at-a-glance look at the main options. And what you'll notice is that the level of intervention really ramps up as the sperm count goes down. For milder issues, you might start with something like IUI. If that's not enough, or for tubal problems, you move to IVF. And for the really severe male factor issues, that's when you bring out the big gun, ICSI. And ICSI is really the ultimate targeted approach. I mean, we're talking about an embryologist selecting a single healthy-looking sperm and injecting it directly into the egg. It's like a specialist hand-planting one perfect seed to give it the absolute best shot. It's incredible technology. Okay, now we're going to do a complete 180 and pivot to the other side of reproductive medicine, contraception. We've talked about cultivating the garden, now let's talk about fencing it off, deciding when not to plant. And this is where things get really fascinating. You remember in ovulation, the thing that's the #1 problem in female infertility? Well, it's also the #1 solution in most birth control pills. They work by creating that same state on purpose. They stop the garden signal for a seed to be released. It's the same biology, just used for the opposite goal. Now, when it comes to emergency contraception, our source material highlights two main choices, and they work in completely different ways. You've got the copper IUD, which is the most effective method, and it works by preventing a fertilized egg from implanting. Then there's the much more common pill, levonorgestrel. Its job is to delay ovulation so fertilization can't happen in the first place. And it's important to point out, the source material makes it very clear this pill is not an abortifacient. It can't end a pregnancy that's already established. And just touching on safety for a second, this slide lays out the clear, logical steps doctors take if an IUD string goes missing. You don't just jump to surgery, right? First, you look with an ultrasound. If that doesn't work, you move to an X-ray. It's a really clear protocol that puts patient safety first, starting with the least invasive options. This quote really underscores a key takeaway from all of this. For a specific problem like a blocked fallopian tube or clogged irrigation pipe, the go-to solution is usually IVF. And it makes sense, right? Why try to fix the pipe when you can just go around it? IVF completely bypasses the problem. So, when you take a step back and look at the big picture, what does all this mean? It means that reproductive medicine, all of these diagnostics, treatments, and technologies, is ultimately a powerful toolkit. And what that toolkit provides is personal choice. The choice to cultivate the garden, or the choice to let it rest. And that really leaves us with a final big picture thought. As these tools for managing our biological gardens get more and more precise, what does that mean for us? How is this technology going to shape our very definitions of family, of timing, and maybe even the future of reproduction itself? It's definitely something to think about.